Lab 7, appendicular division. Okay, so as usual, let me share my screen. It should be booted up. There it is. Yay. Okay, so once you do the axial skeleton, I really feel like when we get to the appendicular, it really rolls because we're looking at the bones, naming the bones. We're identifying particular features on them, assigning functions, A for articulation, P for passageway, M for some kind of muscle, really ligament or tendon attachment, as we did in the axial skeleton. So we're going to go through the remaining bones. That includes all the bones of the arms and the legs, and the bones that attach those arms and legs extremities to the axial skeleton. So we will go through those. There's bones of the upper or the arms or the upper appendages in exercise 1. Then we move on to the pelvis and the lower legs. We're going to classify some joints. We're going to look at the synovial joint model and identify the things you have to know structurally and functionally. And then we're going to briefly define these motions of synovial joints and cartilaginous joints. So back up at the top, we have the clavicle. So when it comes to the clavicle, all you have to do is be able to identify that bone as a clavicle. No particular features on them that you have to know. The scapula has a few, though. The glenoid fossa, or sometimes referred to as a cavity, that functions, because it's nice and smooth, A for articulation. The acromion process functions as articulation. The coracoid process as M for muscle attachment, and the spine of the scapula for M for muscle attachment. And let me just say that, pardon me, it's not as if the acromion process does not have muscles that attach to it, because trapezius inserts on part of that, and then the deltoid muscle originates on part of that. I mean, it also originates on the clavicle as well, but its primary function is going to be articulation, so we can articulate with the clavicle and form the acromioclavicular joint. Okay, we move on to the humerus, the head. That functions as A, articulation. We have a greater tubercle and lesser tubercle, and your deltoid tuberosity. They're all M for muscle attachment. The capitulum and the trochlea are at the distal end of the humerus. Right, those are for articulations. They will articulate with the bones of the forearm, the radius, and the ulna. The medial epicondyle is M for muscle attachment, and the olecranon fossa is A for articulation. The greater and lesser tubercles are at the proximal end of the humerus, so you'll see the head of the humerus and just kind of distal to it, so to speak, as you head away from the axial skeleton and toward the fingers. That's where we'll find the greater and lesser tubercles. The greater tubercle is a large, roughened bump on the humerus, and the lesser tubercle is a smaller one. The deltoid tuberosity is the only mid-shaft structure you have to know, so that makes that a little bit easier as well. Okay, the bones of the forearm. We have the ulna. Right. The ulna is on the pinky side of the forearm in anatomical position. We have the olecranon process, which is this roughened surface on the olecranon, and that's M for muscle attachment. On the opposite side of the roughened side is a scooped out, notched, smooth surface. That's the trochlear notch, so that would be A for articulation. And at the distal end toward the wrist, that's the styloid process. Now, going back to the olecranon process, some people are going to, and in your lecture class, they may say that the function is articulation, kind of similar to what we're saying with the acromion, because it forms a joint. But you have the acromion, and then you have the acromion process. And that's the part where or that's the region, the roughened region, where your triceps brachii muscle attaches to. And that's a rather large muscle. The majority of muscle mass of your of your upper arm, what's called the brachium, is actually triceps brachii, not biceps brachii or brachialis. So it generates and creates a lot of force on that olecranon, and it becomes that big roughened surface, the olecranon process. So you may see elsewhere that they consider it to be an articulation, but to help tie it into the origins and insertions for muscles in the subsequent lab that we're going to be performing in the muscle labs, I use muscle attachment for that. Okay, the radius and anatomical position is on the lateral aspect at the base of the thumb. The head functions as an articulation. The radial tuberosity is a muscle attachment. That's where your biceps brachii muscle is going to attach to. And then just like on the ulna, the distal end has another styloid process. You just have to know the carpals as a group. It's 2 rows of 4 bones. The metacarpals would be the next group. They're the longer shaft of bones, distal to the carpal bones. And then beyond that, or distal to that, we have the phalanges. The thumb has 2 phalanges and every other finger has 3. Okay, moving on to the bones of the lower appendages. We have a male and female pelvis. I'll show you how to quickly identify that. I maybe ask 1 or 2 questions, maybe. But let's look at each side of the pelvis because they're called the os coxa or coxal bones. Is what you consider your pelvis, the right side and the left side. All right, we have the acetabulum, which is this indentation where the head of the femur will create a joint. That's going to be essentially what you call your hip joint. So the acetabulum functions as a for articulation. The pubic symphysis is where the 2 pubic bones meet anteriorly. That can either be, we're going to use a muscle attachment because, let me just say it could be really articulation or muscle attachment, and not to confuse you. But when we're looking at the classification of joints, that's a cartilaginous joint. The 2 pubic bones come together. Remember, that's one of the locations of fibrocartilage. So it's classified as structurally a cartilaginous joint. So because it's a joint, we really could call it an articulation. Right? But also when it comes to the muscles, it's the origin of rectus abdominis. So it also serves as the attachment point for a muscle. So it's one of those that actually technically has multiple functions, very similar to the acromion process. So when it comes to the function of that, and I probably don't even ask it if it's rather ambiguous like that, I would go with A or M. The options, you won't have both of them. Okay, then when it comes to the obturator foramen, that's a hole through the bone. So foramen is always P for passageway. All right, the larger of the bones, and that is on the superior aspect, is the ilium. And on the posterior aspect, when you're looking at from posterior to anterior, you have a large notched out region that's called the greater sciatic notch. And that functions as a passageway. So that's the only structure that actually functions as a passageway without being like a foramen or a canal. And that's for your sciatic nerve to pass through. Staying posteriorly, we have the ischium bone. We have ischial tuberosity and the ischial spine that both serve as muscle attachments. And I call it your sitting bone, the ischial tuberosity, because as you sit there and you kind of roll back and forth on your butt, you feel this bony portion of your butt pushing into the cushion of the seat. And that's your ischial tuberosity. Then we have the pubis bone found anteriorly. There aren't any particular features you need to know, except for maybe the pubic symphysis. Okay, then we move on to the lower extremities, the femur. We have the head of the femur, which functions as an articulation. We have the greater trochanter, lesser trochanter, and the linea aspera, all function as muscle attachments, MMM. The greater trochanter is going to be a large bump on the bone at the proximal end, right? Just distal to the head. And the lesser trochanter is going to be a smaller roughened surface. The linea aspera is a raised line crest of bone on the posterior aspect of the femur. Okay, then we have the patella, which is your kneecap. And then in the lower extremity, below the knee joint, we have the tibia, which is on the medial aspect, of the right leg and the left leg. We have at the proximal end, we have the tibial tuberosity that functions as a muscle attachment. And then inferior to that, there's a raised crest of bone on the anterior aspect of the tibia, called the anterior crest, and that functions as a muscle attachment as well. And then at the distal end on the medial aspect is the medial malleolus. On the lateral aspect of your below your knee and your lower extremity is the fibula. I call it the Q-tip bone because it looks very, very similar at both ends, like a Q-tip does. And the only structure on that is the distal end, called the lateral malleolus. And these malleoli are kind of similar to how we had the styloid processes at the distal ends on both the radius and the ulna. On the tibia and the fibula, we have these larger bumps at the distal ends of those two bones, and they're called malleoli. So you have a medial malleolus on the medial aspect of the ankle, and the lateral malleolus on the lateral aspect on the fibula. They're really what you consider, I guess, like your ankles a lot of times. If you've ever bumped the side of your ankle or the medial aspect, that's what you're bumping, the malleoli. Okay, then distal to that, we have tarsal bones. You need to know two specifically, your calcaneus, which is your heel bone, and the talus. The talus sits on top of the calcaneus, and it has a domed, smooth surface on the superior aspect. And that's how the tibia, listed above, is going to articulate with the foot. So the talus is on top, and it articulates with the tibia. Lateral to that will be the fibula. The rest of the tarsal bones, you just call them a tarsal. They do have specific names, but you don't have to know them. Okay, then beyond that, just like beyond the carpal bones, you have longer shafts of bone. They're called the metatarsals. And then beyond that, or distal to that, we have the phalanges. The big toe has 2 phalanges. All other toes have 3 phalanges, even your little toe. Okay, then we move on to the classification of joints. So all these different joints that we've looked at so far, and there'll be a couple that you have not already seen, like the syndesmoses, and I'll show you a picture of those. All right. And there's another one, actually, the gomphosis. Those are your 2 sockets. All these different joints, we can either classify them functionally by how much movement occurs there, either a lot, a little, or none. And thus the terms synarthrotic, amphiarthrotic, diarthrotic would be your possible answers or choices when it comes to identify the functional classification of a joint. All right. So functional means how much movement occurs there. So as we look at these joints, you can kind of use common sense and go, well, how much movement would I expect to see or find at that joint? And it becomes, I think, a little obvious once you give it a little bit of thought, and then you decide, okay, it's going to be a lot of movement, no movement, or very little movement. So the term synarthrotic essentially means no movement. I don't expect to find any movement there, synarthrotic. Amphiarthrotic means there's a little bit of movement there. Diarthrotic means there's a lot of movement. And that's the majority of your joints, like your elbow joints, the joints in your fingers, in your shoulders, in your spine. Or we can take all those joints and classify them structurally as to what kind of tissue connects the one bone to another at that joint or articular surface. All right, so this is like what tissue binds them together. Is it fibrous tissue, cartilaginous tissue, or is it a synovial joint? All right, so fibrous tissue would be some kind of dense regular connective tissue. Cartilaginous joint will be one of the cartilages we looked at, hyaline, elastic, or fibro. And then synovial will be a synovial joint. Now, synovial joints have certain structures associated with them. That's why we're going to look at that synovial joint model, which is number 4 down here at the bottom, because synovial joints, because of the way they have these synovial membranes, within the membrane, cells secrete the synovial fluid that we find in there. So it's kind of like a water balloon between two bones. And then at the ends of the bones, remember we have those blue structures, called the articular ends of bone that is composed of hyaline cartilage. And then in the case of a knee joint, we might see those like whitish meniscal pads in between those. Those are the fibrocartilages. All right. But the unit of having this synovial membrane, the fluid, the fact that the bones have that articular cartilage there, makes it a synovial joint. And therefore, it imparts a great deal of movement. All right. So when it comes to, we've already listed over to the left-hand side, or I have the structural classification of certain joints. And I started with that. I said, well, these are the fibrous joints, A, B, C, cartilaginous joints, D, E, and then we have synovial joints. And I talk about the types of movements there that occur there. Plane or gliding joints, there are hinge joints, pivot joints, condylar, ball and socket joints, all the types of joints that fall into those categories. I don't ask you to define those terms like planar and gliding, but look at all the different types of movement that you probably covered in lecture, and that falls under synovial joints because of the structural nature of that joint, it provides a lot of movement. Therefore, let's go back up here to the functional terms and structural terms, and over to the far right-hand side, joints that are synovial will also be diarthrotic above it, because diarthrotic means there's a lot of movement. So if it's a diarthrotic joint functionally, it's structurally a synovial joint. And if it's structurally a synovial joint, then you can, answer that the functional classification of that synovial joint is always going to be diarthrotic. They will go together, period. Now, the other terms, synarthrotic, amphiarthrotic, fibrous, and cartilaginous, those kind of mix a little bit. Okay, so let's talk about that. The fibrous joints, sutures. So the sutures we looked at in the previous lab. We looked at the coronal suture or the frontal suture, the squamous suture, the lambdoidal suture, right? Everywhere where we have sutures, right, that is connective tissue, like dense regular connective tissue, holding those two together, all right? The functional classification would be synarthrotic. So you look at a suture, and when we see these, I'm going to remind you of the different types of questions I could ask you, because I could just be pointing to a suture and say, hey, identify, that structurally, and it may be the lambdoidal suture. But if I ask you what is the functional classification of that structure, then you would say synarthrotic. Looking at a suture, you do not expect, kind of logically, normally, any motion to be occurring there. So sutures is not going to have any motion normally. So it's a synarthrotic joint, synarthrotic, no motion. Okay, gomphosis are tooth sockets. And what keeps teeth in those tooth sockets are ligaments, dense, regular connective tissue. So how much movement do you expect your teeth in the tooth socket normally? None, right? So you would write synarthrotic. Syndesmoses, and we're going to see an example of that, are connective tissues that connect the radius to the ulna along, the diaphyseal areas there, and in the lower extremity from the tibia to the fibula. So it's a sheet of connective tissue to keep them together. So it's a fibrous joint. And what kind of movement do we expect to occur there? You're not going to say there's none, but there is a little bit. So those are examples of amphiarthrotic joints. Especially in the forearm, when you picture an anatomical position, all right, moving your palm down and upward, which is, this would be supination and pronation without rotating your shoulder at all. Palms up, palm down, palms up, palm down. Those two, the radius and ulna, have to pivot around each other to a certain extent. So there is movement in there. And that's what makes that fibrous joint amphiarthrotic. Okay, let's look at some of the cartilaginous joints, which we've seen from the previous lab. We have what's called technically synchondroses. That's where a bone meets a bone with just cartilage between them. Our example of that is the epiphyseal plate. It's hyaline cartilage between an epiphysis and diaphysis. We said that's where we have bone elongation, and then it closes down upon skeletal maturity and becomes an epiphyseal line. All right, so let's talk about the functional classification. How much movement would you expect to find at that epiphyseal plate between the epiphysis and the diaphysis of a long bone? None, right? So that would be synarthrotic. Let's look at the symphysis and the intervertebral discs, the IVDs. Those are fibrocartilage locations, right? The pubic symphysis. Sacroiliac joints are considered, that as well, but that's really a fibrous joint. All right. So we have a symphysis, the pubic symphysis, and the intervertebral discs. Now, those are not all like fused together with no movement. They have a little bit of movement. They would be amphiarthrotic. The pubic symphysis found anteriorly, your pelvis twists and turns a little bit. And the discs between each vertebra allow the different vertebrae above and below to have a certain amount of rotation against each other, forward flexion, extension, lateral flexion, to bend to the right, bend to the left. There's movement in there. It's not extraordinary like a synovial joint, but it's amphiarthrotic, some movement. All right, then we go on to the synovial joints, is essentially everything else other than a suture, a two-socket gomphosis, an interosseous membrane between the radius and ulna or the tibia and the fibula, an epiphyseal plate, a pubic symphysis, or an intervertebral disc. Anything else that I point to is a synovial joint. Therefore, the functional classification is diarthrotic. Okay, we've looked at that synovial joint before, but we're going to look at it again. So you're going to be responsible for identifying the articular cartilage, which is at the ends of the bone in blue. Right? What is its function? Shock absorption and to reduce friction. The synovial fluid, the membrane and synovial fluid within that cavity there, that also functions as shock absorption and reduce friction. We're going to look at some ligaments and bones. Ligaments attach bone to bone. Tendons attach muscle to bone. The ligaments provide deep support for the joint. And the tendons, attach the muscles to the bone. The ligaments, you will always see them go from one bone to another. Tendons will be cut and be have a nub to it, so to speak, because that's kind of the language of, hey, we're going to cut the muscle and you're just going to see the tendon, and it's superficial to ligaments because ligaments are always deeper to the muscles than the tendons. The ligaments, you'll be able to see where it attaches bone to bone. Okay, then you should know, at least to a certain extent, a brief definition of the motions that occur at these synovial and cartilaginous joints. Flexion and extension, right? Flexion means decreasing the joint surface or the joint angle, and extension means, increasing the joint angle. So let's say forward flexion and extension in the cervical spine. Flexion would be bringing your chin toward your chest, and extension would be bringing your chin and your head back up into the neutral anatomical position. Flexion is decreasing the angle, extension is increasing the angle. Abduction and adduction. We see a lot of that at, the arms by their side and your legs, together in anatomical position. So ab means away from, and ad means bringing together or towards. So abduction means bringing, these extremities, for example, the arms, in anatomical position. We're starting with our arms by our sides. If we, lift up our arms to our sides, we are abducting, that shoulder joint. We are abducting, taking away from midline and bringing them maybe parallel to your side, to the right and left, like your arms up and abducted, taking away from midline. Adduction or adduction means you're bringing them back down toward midline. Now in the legs, it's like standing on one leg and bringing one leg out to the side. That would be abduction, and adduction means you're bringing your leg back down toward the other leg and standing on both feet. Unless you're lying down, you can't abduct both legs at the same time because you do a split or a fall. But, you could be laying on your back, supine, and abduct both legs. You would bring both legs out to the side. Adduction would be bringing them back toward midline. Pronation and supination, we use that a lot in the palms of the hand. So in anatomical position, arms to the side, palms forward. You are already have your palms in what's called supination because they're forward. Pronation would be rotating your palms to the back or to the wall behind you. Supination means bringing your palms upward and anterior. Right. So what I used to say, or we used to say, well, in supination, picture carrying a bowl of soup, your palms would be upward. Pronation, you just rotate the palms downward. Dorsiflexion and plantar flexion. We do that in the feet. Dorsiflexion, well, the underside of the foot is called the dorsum of the foot. All right. So when you point your toes, your toes are going toward the dorsum of the foot. It's dorsiflexion. And I'm sorry, let me take that back. I just said that backwards. I'm sorry. The plantar surface is on the bottom of the foot. My bad. I think I need more Starbucks. The plantar surface is on the undersurface of the foot. So when you point your toes, that's plantar flexion. Like when you go on your toes like a ballerina, that's plantar flexion. The dorsum of the foot is on the superior surface of the foot. The part of your foot that you can feel those metatarsals, the bony, aspect to it. There's not a lot of fat on the superior, aspect of your foot. Right, so that's called the dorsum of the foot. And bringing your toes toward your nose is dorsiflexion. All right, so undersurface of the foot is plantar surface. When you point your toes, that's plantar flexion. And the superior surface, the bony side, of your foot is the dorsum of the foot, and bringing your toes toward your nose is dorsiflexion. So my bad, I'm sorry that I misspoke. Okay, elevation and depression. We have a couple areas. An easy one to think of is actually the jaw, your mandible. Opening your mouth and letting your jaw drop is depression. And bringing your jaw, closing your mouth and elevating and elevating the mandible and closing your mouth is elevation. Right, so opening your mouth, the mandible drops down, that's depression. Closing your mouth, elevating the mandible like you're going to chew, that's elevation. The scapula sliding on your ribs in the back also do that. As you, let's say, shrug your shoulders, the scapula slides on the ribs, that's elevation. And letting those trapezius muscles relax, that lets the scapula slide downward, so to speak, inferiorly, and it's called depression. Rotation, we have a couple areas where we have rotation. We have the radius on the ulna at the proximal end when you, and again, an anatomical position, pronate versus supinate. The radius kind of pivots around at the proximal end, the ulna. So that's rotation. We have rotation on the occipital bone on atlas and atlas to axis. When you turn your head to the right and left, or like shake your head no, that there's a lot of rotation that occurs in those regions. Circumduction, good example of that is your hip joint and your shoulder joints. You can rotate your shoulder, your arm all the way around these big circles in your glenohumeral joint, in your shoulder joint, and in your femoral acetabular joint, in your hip joint. You can circumduct your femur in your acetabulum, maybe big circles with your leg. That would be circumduction. Okay, so other than me misspeaking about the dorsiflexion, plantar flexion, that should all be good. Right? So let's now share, or let me share the images. Scroll down. There's our axial skeleton and our appendicular. Okay, so let's go to the images. All right, so the question, what bone is this? That is a clavicle. So, you don't have to know any other feature or functions associated with that bone other than just it's a clavicle. Okay, now we have the scapula, right? And this, and I will say also, I don't require you to know left and right, but you should know that you are looking at someone's back. And so therefore this is going to be a left, but this is looking at it, at a skeleton from the backside of the skeleton. The other surface, opposite surface where the number 2 is arrow, would be the surface of the scapula where it meets with the ribs. Okay, so we're pointing to these particular structures. We're pointing to number 1, number 2, number 3, and number 4. So the question is, what bone is this? It's the scapula. 1 is pointing to the glenoid cavity or fossa. 2 is pointing to this big raised ridge of bone. That's the spine of the scapula. 3 is pointing to the acromion or the acromion process. And 4 is pointing to the coracoid process. Sorry. Coronoid process is close to the nose on the mandible. The coracoid process is found on the scapula. Okay, so then you should know what the functions are. All right. Well, the spine of the scapula is a muscle attachment. The acromion process and coracoid processes are, the acromion process, we said we're going to say that it's an articulation. Not that muscles don't attach there, but it makes it easier if we just use articulation. The coracoid process 4 is a muscle attachment. And 1, of course, the glenoid fossa is articulation, if I didn't mention that before. All right. So although the functions aren't listed here, it's part of your lab exercises that we performed. Okay, then we're looking at the next bone. This would be the humerus. Here we have 1, 2, 3, and 4. And there's going to be some other features at the distal end. This is the proximal end. All right, so 1 is pointing to the smooth surface there. That would be the head. We have 2 bumps on the bone. We have a big one out laterally, number 3. That would be the greater tubercle. And 2 is pointing to the smaller of them. That would be the lesser tubercle. And 4 is pointing to the only mid-shaft structure you have to know. And that's the deltoid tuberosity. That's where your deltoid muscle inserts. All right, so the head, the lesser tubercle, greater tubercle, and deltoid tuberosity. Again, know their functions. Okay, then we move to the distal end, because the humerus has the most features on it that you have to know. We have number 1, number 2, 3 is pointing to the backside, this indentation. And for some reason, he is not pointing to the medial epicondyle over here. It may be in a subsequent picture. But this bump that's above number 2, that arrow, this bump here, that's called the medial epicondyle. So number 1 is pointing to the capitulum, and 2 to the trochlea. 3 is pointing to the olecranon fossa, this indented region on the posterior aspect of the humerus. 1 and 2 are both smooth surfaces at the end of the bone, so they function as articulation. This is where 1, you will articulate with the head of the radius, and 2, you're going to articulate with the trochlea. Right? Remember we said the trochlea, the ulna has a trochlear notch that's scooped out. That's to pivot around this end of this articular end of the bone, number 2. And then 3 is where the olecranon is going to rotate into. So that scooped out surface is going to function as an articulation. All right. And so, great. So the bone is turned around. We're looking at the posterior aspect. This scooped out region here, 3, that's the olecranon fossa. And now I'm wondering, I hope I mentioned that previously. If not, that's the olecranon fossa and its articulation. It's in the list there, but sometimes I start talking and I accidentally skip over a structure. So again, my bad. I need a sip of coffee, maybe some Starbucks. Okay, so we're moving on to the forearm. This is the radius. The head of the radius is this portion here up on top. 1 is pointing to the radial tuberosity. That's where your biceps brachii muscle inserts. And at the distal end toward the wrist is this little pointy region. That's the styloid process. Both the radius and the ulna will have styloid processes. So the radial tuberosity acts as a muscle insertion. The head, I'm not sure why they're not pointing to the head here, but that articulates, with the humerus here. And then 2 is just a styloid process. There's no function. All right, this is the ulna. We're looking at it sideways. All right, we have the 1, which is pointing to the olecranon or the olecranon process. I refer to as the olecranon process. The scooped out region here is the trochlear notch, and the distal end, the little pointy part there, that's the styloid process. So the olecranon process on the back there, that big roughened surface, is M for muscle attachment. That's where your triceps, brachii muscle is going to insert. 2 is that smooth articular surface that will pivot around the trochlea of the humerus. And then the indented portion that we just said, the olecranon fossa, this portion of that bone is going to pivot into, and it allows you to fully extend your elbow. Okay, then we're looking at hands. Number 1 is pointing to those funny little bones down there. We have 2 rows of 4 carpal bones. You don't have to know them individually. They're just carpal bones. Then distal to that, I said these are the long shafts of bone. Those are the metacarpals. And then beyond that, the thumb has 2 phalanges. Every other finger, 1, 2, 3 phalanges. 1, 2, 3 phalanges. 1, 2, 3, and even the pinky finger, 1, 2, and 3. The number 3 arrow is just sitting on one of those bones. Just know them as a group as phalanges. So we have carpals, metacarpals, phalanges. You drive a car with your carpals. You walk on tar with your tarsals. That kind of helps you keep this straight as well. Right. All right, now we're moving down to the pelvis and the lower extremities. Here is one side of your pelvis, often called an os coxa. We have 3 major bones that form the pelvis. They grow, separately, just like your other bones, but they're like the bones of the skull, but as they grow, they will end up fusing together and form one large bone. So we have bone 1, bone 2, bone 3. 1 forms the or is the pubis bone, and when it meets the other pubic bone anteriorly, it forms the pubic symphysis. Posteriorly, number 2 is your ischium. That's your sitting bone, I call it. And then superiorly, the majority of this vanilla colored bone model is the ilium. All right. Pubic or pubis bone, ischium, and ilium. Okay, then let's start looking at some of the features. Here we're pointing to this bone. That's the pubis bone. This hole is the obturator foramen. What's its function? Well, what does any foramen function as? It's a passageway, P for passageway. Then when we look at the ischium, there are 2 structures to know. The ischiotuberosity, which is this big roughened surface here at number 1, and then the smaller little ischiospine at number 2. They both serve as muscle attachments. Above that is the greater sciatic notch. That's what 1 is pointing to, the scooped out region superior to the ischiospine. And that functions as P for passageway. Okay, now we're looking at a femur. We have the proximal end. 1 is the head of the femur. We have larger bumps on bone called trochanters on the femur. We have the lesser trochanter, number 3, and the greater, number 2. That's a big mamma jamma. And you can't quite see it on here, but about where the base of the 3 arrow is the beginning of and traveling way down along the back of the shaft or the posterior shaft of the femur is the linea aspera. When you see them in lab and you're able to hold them, you can feel this very prominent raised ridge of bone. That's the linea aspera. So 1, the head, smooth surface articulation, and 2, 3, and 4, all muscle attachments. Okay, what is this bone? That's the patella, the largest sesamoid bone of the body, your kneecap. Then we move to below the knee. We have the largest bone below the knee. That's the tibia. All right, and I'm not sure why it always turns sideways, but in any event, we have the bone is the tibia. 2 is pointing to, and I'm sorry, number 1 to the right-hand side is the proximal end of the tibia. This is where the ends of the femur will articulate on this surface here. All right, what 1 is pointing to is this bumpy, roughened surface here. That's your tibial tuberosity. That is for your quadriceps tendon. All 4 of your quadriceps muscles form one tendon and inserts right here. So that's a lot of force being generated on that. So it's a rather large, roughened surface. So tibial tuberosity, muscle attachment. Here, this raised ridge of bone, you can barely see this at the tip of the number 2 arrow. That's your anterior crest, muscle attachment. And then the distal end, number 3, it kind of looks like a very large styloid process. And that's your medial malleolus. No function. I won't ask you a function. To the lateral aspect of your lower extremity is the fibula bone. So you see how it kind of looks the same at one end and the other. I mean, there's differences, but I call it the Q-tip bone. You only have to know one structure, and it's at the distal end, and that's the lateral malleolus, because the fibula is on the lateral aspect of your lower extremity. Okay, this picture is turned right side up, but it's pointing to the same things. Okay, now we're going to look at the foot. We have 2 big tarsal bones that you have to know. The bone that sits on top and articulates with the tibia is the talus. And here you can see the smooth surface to it. That's another trochlear, by the way. But anyway. And then below that, your heel bone, that's your calcaneus. The other bones that are underneath number one to the right and left, you can see these other smaller, cubey, unusually shaped bones. Those you just know as a group. Those would just be like a tarsal bone. But now you can see beyond that, these longer shafts of bones, those will be the metatarsals, similar to your metacarpals. So one is sitting on all of these long shafts of bone. And then anything beyond that, even in the little toe, look at the pinky toe, three phalanges, all phalanges. The big toe only has two phalanges. All right, so here we have some pictures included from the lab book that labels up the anatomy you have to know. They're highlighted in yellow. Oh, let me go back. I'm sorry, I went too fast there. In this picture, here we have the humerus, and then over to the right, we have the radius and the ulna. You see this white connective tissue here, right in the center? That is that interosseous membrane. When I was talking about the joint classifications, and I said part of the, fibrous joints, one of the examples we have not looked at, in a picture are the interosseous membranes. We have one between the radius and the ulna. We also have one between the tibia and the fibula. And that keeps them from popping apart from each other. So that's that interosseous membrane here. This would be the radio-ulnar interosseous membrane. And then we have a tibiofibular. You can look at these on your own. Carpals, metacarpals, phalanges. As I said, you don't have to know the individual carpal bones, but if you want to, you can. Beyond that, the metacarpals and the phalanges. When we look at the pelvis down below, we can look at each side, and highlighted are the structures you have to know. And, students often are just like, oh, this is too much for me to learn. But technically, these are all the features on each side of the pelvis, that you could be held responsible for, but we don't make you know all of them. Below that, we see these two pelvises with their sacrum and coccyx. Right? And this is a difference between a male and a female pelvis. The male is here on the left-hand side, the female on the right-hand side. Right. The female, if you look at what's called the pubic angle, so here anteriorly is the pubic symphysis on the male, and if you can see my little arrow here on the female. Right. Below the pubic symphysis, we have what's called the pubic angle. And this angle here in the male is rather narrow, right, and very small. On the female, do you see how broad that same angle is below the pubic symphysis? It's much, much broader. And that just visually is a very easy cue as to which is the male and the female. The females, this what's called the pelvic outlet, and this opening here is a lot more oval, and this allows or provides for passageway, birth canal and passageway. Okay, now we're at the femur and the tibia and the fibula here. So again, highlighted on the femur pictures, are the structures you have to know, and also on somewhat, there'll be another one on the tibia. Not sure why I didn't get the tibia tuberosity here. It might be in the picture below. But to the upper right-hand side of this page, you see that white connective tissue, that interosseous membrane between the fibula and the tibia. Right? That's the other tibial, the interosseous membrane. So we have one in the lower extremities and the forearm area. This is pointing to the bones of the foot, the talus, the calcaneus. As a group, these others are just, you just have to know them as tarsal bones, metatarsals, and phalanges. Okay, when it comes to those joints and articulations, this is another way of organizing the exercise 4, or actually exercise 3 of your joint classifications. The way I put them on that page you can use that and apply over here in a little chart form. So either method is fine. On the left-hand side vertically, we have the structural classification underlined in green. And when you have structural classifications of joints, your possible answers are fibrous, cartilaginous, or synovial, period. Don't answer the otics like a semi-arthrotic, amphiarthrotic, diarthrotic. Structural is the tissue that holds those bones together. It's either fibrous, cartilaginous, or synovial. All right. So going across on the horizontal, our fibrous joints are sutures and gomphosis. Farther in the midline here, we have the syndesmosis and the interosseous membranes, and that's it. For the cartilaginous joints from left to right, these are the locations you've looked at. You have an epiphyseal plate, we have the symphysis, we have a pubic symphysis and intervertebral discs. And then below that, synovial joints, everything else that I could point to or look at, and that includes all the planar or gliding joints, the pivots, the hinges, the condyloid, or the bone sockets. I'm not going to ask you to look at a joint and tell me what kind of synovial joint it is. Is it a pivot? Is it, a hinge? But you can see the kind of motion that's going to, occur there. Okay. Now, on the top row, we have our functional classifications in green. On the vertical, over to the left to the right, we have synarthrotics, amphiarthrotics, and diarthrotics. All right, so the synarthrotic joints are the sutures, as we looked at in the skull, and the gomphoses, which are the tooth sockets. If we're looking at an epiphyseal plate, that's going to be a synarthrotic joint as well, right? The suture and gomphoses, if I point to one of those joints and I ask you the structural classification, you'd say it's fibrous, right? Because it's in the fibrous horizontal line. But if I asked you the functional, how much movement occurs there classification, you go, well, there's no movement in the sutures and the tooth sockets normally. So you would say synarthrotic. When it comes to an epiphyseal plate, what is the structural classification? Cartilaginous. What is the functional classification? Synarthrotic. Over to the middle column, the amphiarthrotics, those interosseous membranes between the radius and the ulna and the tibia and the fibula. What is the structural classification? It's fibrous. We're on the fibrous horizontal line. What is the functional classification? Now we're going vertically. It's amphiarthrotic. If we point to a pubic symphysis or an intervertebral disc, again, over to the left, what is the structural classification? It's cartilaginous on that horizontal row. What is the functional classification? Amphiarthrotic. There's a little bit of movement there. Now, everything else, like a shoulder joint, like atlas on axis, the occiput on C1, the hip joint, these are all structurally classified as synovial joints because they're going to have a synovial membrane, the articular, the hyaline cartilage at the articular ends of the bone. It's going to have synovial fluid. It's a synovial joint. Functionally classifying those same joints, they are diarthrotic because lots and lots of motion occurs there. So synovial joints are functionally classified as diarthrotic joints and vice versa. So I hope that makes sense. Okay, and that is the end of this lab.